Hi, welcome back to Student Nurses Success, where we're continuing our GI series. This particular video is going to cover liver dysfunction. Remember, you can find a link to the maps in the comments. Let's go ahead and get started. What I think is of the most important is to understand what the liver does. When we understand what the liver does for our body, then it's an easy way to understand what is going wrong when the liver doesn't work well. So I've kind of identified the eight biggest things here that are going to kind of help guide you through liver dysfunction and what you're going to see in patients who have liver failure. The first thing the liver does is that it removes toxins. We know that drugs and toxins can build up in liver failure and that many drugs are metabolized by the liver. So, in patients who have liver dysfunction, you want to watch for that toxicity and buildup. The second thing that the liver does is it removes bilirubin. Now, bilirubin is from red blood cell breakdown. So as red blood cells die and break down, they release bilirubin into the bloodstream. Now, bilirubin needs to be cleared out of the blood. If it starts to rise, the bilirubin levels rise in the bloodstream, it can poison the brain. So the body gets rid of bilirubin through the liver. So as bilirubin is circulating through the bloodstream, you can't get rid of it that way. So what it does is as it travels through the liver conjugates it or attaches bilirubin to bile. And when it conjugates and attaches it that way, then bile takes the bilirubin out of the body by way of the intestines. So what we see in liver failure is that these bilirubins, because the liver cannot conjugate, we will start to see a rise in bilirubin levels. The liver is also has a big job in synthesizing proteins such as albumin and clotting factors. So when the liver is not functioning well, the body becomes protein deficient, and we know that protein deficiency leads to third spacing, edema, and the buildup of ascites, which is fluid in the peritoneal area, which is typical of individuals with liver failure. We also know that because it's not synthesizing clotting factors, patients with liver failure are at high risk of bleeding. The liver is important in storing vitamins and minerals, so individuals may be vitamin and mineral deficient if they have liver dysfunction. Now, liver also makes bile. And again, we talked about how bile conjugates to bilirubin, and that's how we get rid of the bilirubin. But also, bile breaks down fats. So, as we eat fats, the bile gets into the intestines and helps break down those fats and makes them usable. We know that the liver also makes cholesterol, and although cholesterol has a little bit of a bad rap with cardiovascular disease, we do need a certain amount of cholesterol in our body because it's important for tissue repair. The liver also plays an important role in metabolism, specifically glycogen storage. Extra glucose that we don't use is stored in the liver in the form of glycogen, and it's stored there for times when we are not eating. And so patients with liver dysfunction are unable to release that glycogen at those times when they're not eating. And so we start to see a decrease in blood sugars for them. The liver metabolizes steroids and androgens, and so we may see a buildup of estrogens or the inability to metabolize steroids in liver failure. And lastly, the liver converts ammonia to urea. Now, ammonia is a byproduct of protein metabolism. So as we break down proteins, we get a byproduct of ammonia. The problem is ammonia, like bilirubin, if the body has too high a levels circulating in the bloodstream, it starts to kind of poison the brain and the neurological system. So what the liver does is it converts ammonia to urea, and urea is then excreted through the urine. So in patients who have liver dysfunction, they're unable to do that conversion, and ammonia levels increase in their body and lead to encephalopathy. So let's go down here. I know I'm kind of jumping around a little bit, but I want to talk about this thing of jaundice and bilirubin just a little bit more detail. So we know that bilirubin is from the breakdown of red blood cells. So let's say you have a bruise. The first part of the bruise is it's going to turn purple and blue. And eventually, as that bruise starts to kind of get cleared and absorbed back into the body, it starts to turn yellow and green before it finally disappears. That yellow green is actually the bilirubin from the red blood cells breaking down. So, when we see jaundice, which is a sign of liver failure, what that is excessive bilirubin. So, jaundice is the yellowing of the skin from excessive bilirubin. And we can sometimes see it in the sclera, and sometimes the skin just takes on kind of this yellow green appearance. So the body or the liver is responsible for getting rid of bilirubin. And if it cannot do that, then the bilirubin, as it builds up in the bloodstream, is going to start to yellow the skin and cause jaundice. Now, there's a couple different things that we need to talk about. Prehepatic jaundice, hepatic jaundice, and posthepatic jaundice. Now, prehepatic jaundice is from excessive amounts of red blood cells that are breaking down. So it's before the liver. What's happening in prehepatic jaundice is that you are basically overwhelming the liver's ability to conjugate the bilirubin because there's just too much. The liver just is overwhelmed. There's too many broken red blood cells for it to take care of. That would be a cause of prehepatic jaundice. What usually causes that is maybe if there's extensive trauma, you're in a car accident and you have massive trauma and bruising, or maybe this thing called RH incompatibility when we have hemolytic disease of the newborn. Sometimes when mothers are RH negative and the baby's RH positive, the mother can actually attack the baby's red blood cells and break them up, and the baby becomes very jaundiced, or basically anything that causes excessive amounts of broken red blood cells in the bloodstream and just overwhelms the liver's ability to process them. In cases of prehepatic jaundice, we will see increased levels of unconjugated bilirubin because the liver can't do its conjugation and can't combine that bilirubin to bile. Now, in hepatic causes of jaundice, we also will see increased levels of unconjugated bilirubin. In hepatic causes of jaundice, that means there's actual damage to the liver. And that's where the problem is. The liver is failing, the liver's dysfunctioning. There's maybe cirrhosis of the liver or maybe alcoholic liver disease. And in these particular cases, the liver's just too damaged to conjugate. And so the bilirubin levels will still remain high. And we will see this as increased unconjugated bilirubin levels. So the bilirubin just continues to circulate through the bloodstream and can't get out of the body. The last cause of jaundice is what we call posthepatic. So this is after the liver. In posthepatic, the liver was able to do its job and the liver did what it needed to do. It conjugated the bilirubin and the bile. The problem is that for some reason we can't get that conjugated bilirubin and bile out into the intestine. Usually it's because there's either a gallstone or some type of blockage in the bile duct. And so we see here, this right here is your gallbladder, and this is the bile duct, and this is the common cystic duct. And if there's a blockage here, or some kind of stone or blockage, then bile starts to back up into the liver and actually causes liver damage that way. And what we do see is increased levels of conjugated bilirubin because the liver did its job, it conjugated it, but it can't get out of the body. So, depending on what the lab value is, we can identify if the problem is before the liver, inside the liver, or after the liver. So, let's move over and look at our lab values here. When we have liver dysfunction, what we see is often a rise in what we call liver enzymes. And our liver enzymes are the AST, the ALT, the ALP, and the GGT. What we see is as the liver is inflamed, damaged, hurting, not functioning well, these enzyme levels will continue to rise higher and higher and higher and higher. And those indicate that there's inflammation and damage in the liver. Now, liver enzymes can be elevated with some medications. And in fact, what we do for some medications, that's how we monitor, are we getting too much of that medication? For example, statins are processed through the liver, obviously, because they lower cholesterol levels. And so we monitor liver enzymes in individuals who are taking statins to make sure that the statin dosage is not too high or that it's not affecting or damaging the liver. As we've talked about, we can also look at bilirubin levels to indicate if there's liver damage. And these levels will increase if the liver is having problems. Remember, if we see an increase in the unconjugated bilirubin, the problem is before the liver or at the liver. If we see an increase in conjugated bilirubin levels, the problem is usually with the gallbladder, the cystic duct, or the common bile duct, or some place that leads the bile out of the liver. Albumin's another lab value to take a look at. Remember that the liver plays a role in protein synthesis, and so when protein levels in the blood start to decrease from liver damage, then we will see a drop in albumin. And then the last lab is PT or clotting time. We will see this prolonged or increased in liver disease because remember, the liver plays a role in manufacturing clotting factors. And if it's not making enough clotting factors, then patients are going to bleed more easily. So let's talk about the causes of liver dysfunction. So we talk about the term cirrhosis, and the term cirrhosis just really means scarring or fibrosis of the liver and ultimately liver dysfunction. So here is a nice picture of a liver that has cirrhosis. It's very scarred, fibrotic, hard. It's not working well. It's not a healthy looking organ. There's lots of different things that can cause liver dysfunction, one of which is drug toxicity. So we can damage the liver either by prescription medications or by illicit drugs. So medications that are metabolized by the liver, if we give too much or we don't monitor them closely, can ultimately damage the liver. Hepatitis is another cause of liver dysfunction. Hepatitis is a viral illness. There are multiple types. A, B, C, D, and E are probably the more common ones. We're just going to talk about three of them here. But the first type of hepatitis, hepatitis A, is transmitted through the fecal oral route. So we find that in foods or in restaurants that may have outbreaks. Someone who has hepatitis A, if they're preparing food or touching food and not washing their hands, then they can transmit it to others. Hepatitis A is acute. It is self-limited for the most part. Most people do. Uh, it does resolve with supportive care. However, there is a risk of long-term damage, and you can have some problems while you're in the acute phases. Hepatitis B and C are both transmitted through blood and body fluid. Now, both of these are chronic in nature. And the difference between B and C is that for hepatitis B, there is no cure. And for hepatitis C, there is a cure. However, for B, we have a vaccine, and there is no vaccine for hepatitis C. So the next disorder is biliary cirrhosis. So biliary cirrhosis is when the bile ducts get clogged, leading to a backup of bile into the liver. And this is commonly from gallstones or cholecystitis. And again, this would be a post-hepatic cause of jaundice. And again, we've got this picture down here where I kind of showed you where the backup in the bile duct. Fatty liver disease is another cause. In some individuals, they have excessive storage of fat in the liver, and that fat causes inflammation and kind of takes over the tissues, and fat won't do the work of the liver. We see this more commonly in those with obesity, high triglycerides, metabolic syndrome, or even from some medications. Alcoholic liver disease is a common cause of cirrhosis as well. We know that alcohol, metabolizing alcohol, is cleared through the liver and it produces toxins that damage the liver. So, too much alcohol over time will damage the liver and cause cirrhosis. And the last is liver cancer, certainly would lead to liver dysfunction. And then let's move on down here and finish up with the complications of liver dysfunction. Remember, these are what happens when the liver does not do the work that it needs to do. And so you can relate a lot of these to the top of the map where we talked about what the liver is responsible for doing. But in liver, what we see first off is the jaundice. And the jaundice is from these increased bilirubin levels in the bloodstream. And we can see either increased conjugated or increased unconjugated levels depending on where the problem is, before the liver, inside the liver, or after the liver. The next thing we see is portal hypertension. Now, this is not systemic high blood pressure. This is not blood pressure you can measure with a blood pressure cuff. What we see is elevated pressure in the portal veins, and the portal veins are these blue veins here. The portal system actually brings blood from the intestines to the liver and allows it to kind of detoxify. So it pulls nutrients out of the gut and it runs all of that through the liver, and the liver detoxifies everything that we eat. Well, what happens in liver failure is if the liver is not working well, it starts to get hardened over time. And if it's hard, then blood doesn't flow through it very well. And in fact, blood actually backs up and we start to see elevated pressures in these portal veins. As these veins get higher pressure, they stretch and they get thinner and thinner and enlarge. And we call these varices. Just like you would see in varicose veins in your legs, we have these throughout our abdominal area and wrapped around our esophagus. And what happens is, as these veins get larger and larger and larger, as the pressure increases, as the liver works less and less optimally, they will start to leak and bleed. That is worsened by the fact that we have decreased clotting factors in liver failure. So what we develop is esophageal varices. And so that's kind of this picture here where you start to get this stretching of kind of vessels around there, and they start to get stretched out and they will start to leak and bleed. You'll also see them throughout the abdominal area develop. The next is what we call portal or hepatic encephalopathy. Encephalopathy is a poisoning of the brain from toxin buildup. We see the buildup of ammonia because remember, the liver cannot convert it to urea any longer. So ammonia levels rise in the bloodstream and they cause what we call a neuropsychiatric manifestations. That includes confusion, altered coordination, tremors, and something called asterixis, which is where it's a neurological condition where kind of a shaking and tremoring will occur. And we also, as the ammonia levels get higher and higher and higher, we start to see the development of cerebral edema and damage to the brain. And last, advanced disease. We always know that when one organ goes down, it's generally a domino effect, and we start to see other organs be affected. So we see the development of hepatorenal failure. And that's because we have all this blood pooling in these portal veins, and it actually decreases volume. And we see is a pre-renal kidney failure from decreased blood flow to the kidneys. And so now the kidneys are harmed because they're not getting enough blood. And that's because the portal hypertension and the pooling of blood. So we start to see renal failure develop, and then also the development of ascites or the pooling of fluid in the peritoneal area. And there we go. There's your completed map on the liver. Make sure to tune in for the other videos in our gastrointestinal series. And remember to like and subscribe to our videos so you're up to date on all our new ones.